go ahead and get started on the head talk about concussions. I'm Chris Giza, and I'm the director of the UCLA Steve Tisch Brain Sport Program, but I've also worked very closely with the Academy on the issue of sports concussions. When I grew up on a farm in West Virginia, the ways you got concussions were falling out of a tree, or wrecking your dirt bike, or maybe falling off an animal you shouldn't have been riding on. So, yes, horses that hadn't been broken, but also cows. Don't ask. And my friends in the suburbs, they got their concussions the regular way, playing football, wrestling, and things like that. And we all pretty much approached them the same way. Yeah, so what, right? You kind of shrug it off, go back and do whatever you're going to do. And for the most part, people did okay, but I'm sure some people had trouble. And now things have changed. What's all the fuss about sports concussions? The dialogue is very different. And sports that, we used to consider, not even very tough sports like soccer, are now at the forefront of changing rules for the way kids participate in them and to limit things like headers. Now, I appreciate that's not a header, okay? That guy's getting a ball kicked into his face, so you can certainly get concussions in sports that are not full contact, and you can also run into each other when you're going up for a header. So currently, we're paying more attention, and even sports that we didn't traditionally think about are now part of our thought process. But has much changed? Football used to be the big concern, and it is still, but this isn't a new thing. In fact, back in 1912, they were doing this kind of helmet testing for headgear for football. Now, it's not as high-tech as the lab at Virginia Tech, but most people may not realize around this time, American football players were dying of subdural hematomas and skull fractures. Well, hopefully nobody's remembering, because that's a long time ago. But people were dying of it, and Teddy Roosevelt told the college presidents, get your act together, or you may find that the sports are going to be regulated or going to be banned. Okay? And so the NCAA was formed, and whatever you think about the current mission of the NCAA, its original mission was for health and safety of the athletes, and they instituted rules changes. They got rid of the flying wedge. They started instituting helmet protectors and things like that. So the story about concussions is changing, but the fact that concussions are there has been around for a long time. And in fact, it's been around a really long time. It's been back centuries ago. Sports were called war, and you beat up on your neighbors and you took their treasure. And in the Iliad, you may remember, Hector took a blow to his head, and they describe it very well. It brought him to his knees. He describes feeling nausea. There was some alteration in mental status. Clearly, this was a concussion. Now, like many good athletes, he didn't stay away from contact activity. He went back to play. He went back to war, and it worked out badly for him, as it often does if you go back prematurely. If you don't remember, Hector was killed by Achilles and then dragged around Troy behind his chariot multiple times. So that's a bad outcome from an early return to play. All right. In the 1800s, Sir Percival Pott in England described probably the first what we would consider traditional sports neurology, neurosurgery kind of case. A young boy was standing by a man playing cricket who swung the bat back and cracked the kid in the head, and he was knocked senseless. And then he proceeds to describe the symptoms of concussion and probably something more severe, probably a depressed skull fracture that was managed and led to some complications, but probably the first presence in the medical literature of some sports neurology. Now, neurologists have been, to some extent, surprisingly absent from the discussion related to sports and neurological injury. It's not something that we have traditionally learned much about in our didactics. Mild TBI was not something that we saw much in clinic. There's not much we do, and if they should go to their primary doctor, or if it's more severe, they should go to the emergency room or see the neurosurgeon or be admitted to an ICU. But there were some visionaries in neurology who sort of opened the door for this. Jim Kelly in Colorado wrote the Colorado Guidelines and the first AAN sports concussion guidelines. And Barry Jordan, and both these guys are still practicing and probably still here. Barry Jordan wrote the first sports neurology textbook. And is still active in combat sports and in the sports neurology section. The AAN now has a sports neurology section for over 5 or 6 years now, and it's a pretty big section, and there's growing interest in this. And I think it's important to understand that while we're just starting now to pay more attention to something we probably should have been paying attention to for a long time, there are a lot of other practitioners out there also who've been doing this. Sports medicine, for sure, has been doing this for a long time. Neuropsychologists, for sure, have been in it. So we want to get back into the game, but we want to do so in a way that acknowledges our colleagues' expertise and work collaboratively. So what are the kind of things that a neurological care provider should know when they're dealing with sports concussion? Well, I was just talking with a young gentleman about different type of assessments for concussion, okay? And there are all different kind of tools, reaction times and number reading tests and computerized tests and balance tests and SCAT this and SAC that. And the real question is, okay, which of these are the appropriate tests to use? And let's not abdicate our clinical thinking when evaluating patients with concussion. Don't forget, there's a neurological history and a neurological exam are part of the diagnosis. And the diagnosis is a clinical diagnosis. There's not a single test that's going to tell you who has a concussion. Okay? But how do you know with all of them out there? The New York Times recently had an article called Concussion Incorporated. And it talked about all the different businesses that are out there, making new devices, making new tests, making new machines and things for treatment, and marketing them to the community at large with varying levels of validation and scientific rigor. Okay? Who better to judge the neurological rigor of these things than neurologically trained clinicians and investigators? Okay? And the onus is on us as a specialty and our colleagues in the other medical specialties to really hold fast to that. So there are a lot of different tests out there. We need to be familiar with these. How about the approach to management of concussions? One of my good friends, Kevin Guskowitz, says, if you've seen one concussion, you've seen one concussion. Everybody wants a concussion protocol. Every school is clamoring. What's the concussion protocol for this kid? I would argue that there's not really a protocol. There's a process. And the process, again, means you don't abdicate intelligent thought. You have to have decision points, and you have to reevaluate as things go along. So a process might include a pre-participation evaluation, and you might use some of those tests, and don't forget your neurological history and examination. Okay? It might have to be abbreviated for screening. And then at the moment of injury, often there's not a neurological provider, right? There's going to be a coach or a parent or somebody using a screening tool, or maybe nobody. Okay? So when in doubt, sit it out. And that's the mantra that we've said and other organizations have said. When you don't have neurologically trained people, when you don't have medical experts there, and you think a concussion has occurred, then that individual should sit out. Then there's initial assessment. Now, neurologists don't have a corner on this. There are other specialists like neuropsychologists, primary care sports medicine, other emergency room doctors who have varying degrees of expertise here also. But somebody who knows about concussion should do an initial assessment, maybe using some of those earlier tools, and then come to some approximation of what's the probability that an injury occurred here. And then if an injury occurred, then again, it's not a protocol. Then you have to do serial assessments, see what is the symptom burden, see what's the individual, what's their gender, what sport are they in, how old are they, and tailor their treatment to those things. They need to be protected from injury, that's true. But does that mean they need to be protected from homework? Nobody I know got a concussion doing homework, okay? Your symptoms can get worse, that's true, but I think that's a different thing. And so we need to make sure that our patients understand that. We know that when we explain things to patients with concussion, they have about a 15 to 20% likelihood of developing chronic post-concussion syndrome. So if we just give some counseling to them and help them manage their activity, we can reduce the likelihood of chronic symptoms. If that was a medicine, everybody would be prescribing it, but there's good evidence that it works. So we should do different type of treatments, and at some point, for most patients, the symptoms are going to improve or they're going to be on the mend. And then the second part of the management for this is what distinguishes it a little bit from other conditions, is that the individuals are getting better, and then you want to have them gradually return to activity. And then maybe gradually return to physical activity. And then almost certainly return to the at-risk activity. And so another gentleman asked me, what's the difference between sports concussions and concussions? Well, the reality is the brain doesn't care, right? When you hit your head and it moves a certain way and it doesn't work, it's a concussion. It doesn't care if you got that playing football or driving your car. What it does care about is what happens after the concussion. And what happens after the concussion in the setting of sports and perhaps in the setting of some risky occupations like military service is not only is there a desire to return to full cognitive ability and full physical ability, but to return to physical risk. And so if you are in a headache clinic and you see your football player who had a concussion and you tell him, wow, you had a bad headache playing football, you should just quit football and you won't have that problem with headaches anymore. That player is going to go somewhere else and you're not going to be able to help them, okay? So you have to work with them, and as long as it appears there's a way to safe recovery and they're a competent individual who can make a decision, you have to help along those lines. If at some point somebody's impaired, then you may have to have a different discussion. The other thing that's important with the concussion process is not every single symptom you get after a concussion is a concussion. Okay? People have migraines, people get dehydrated, people are anxious. Okay? And so it's important to have a differential diagnosis and to tease them apart, and if they're not concussed, then to manage them appropriately. So, in 2013, I had the pleasure of culminating really 4 years of work working on the AAN evidence-based sports concussion guidelines with my colleague Jeff Kutcher and a multidisciplinary team of co-authors who represented people outside of neurology as well as people in neurology. We had adult and child people, we had neuropsychologists, PMR rehab, and followed strict evidence-based guidelines, and those were released in 2013. After reviewing thousands of abstracts and arguing a lot about different things, you'd think Jeff and I had enough, but the next step was to get the message out there, and that was the idea for the Sports Concussion Conference. The first and only AAN-sponsored conference designed around a single diagnosis. Okay? And the vision was that this would be the go-to meeting for concussion education, clinical management, and research, and the meeting had to be multidisciplinary. Our goal was half being MD neurologists and the other half being other folks who are stakeholders in concussion. So now, after looking at thousands of abstracts and writing guidelines and then proposing a meeting to the AAN where we wanted almost half of the people not to be neurologists, and my fellows were thinking maybe I was having a little bit of problem. And so they did some selective cropping of a little article to say that perhaps concussion was suspected for me and Jeff. And you'll have to judge from those glassy smiles whether it was too much literature review or whether we were thinking forward. At the meeting, we were able to review the AAN Sports Concussion Guidelines. Hopefully most of you are at least familiar with these. They're on the website in full length as well as in summary form, and ancillary materials that can help you, handouts for parents and coaches and medical providers. There's an app. There are a number of other things there. So that's been out there. We also had breakout sessions for different levels of sport, high school, college, and pro. We had the didactic sessions focused on sort of the natural history from acute concussion to post-concussion symptoms and syndrome to the risk for chronic neurodegenerative problems. And we tried to present research in a way different than you hear in the media, that there would be balanced presentations based on the evidence and not on hype. And we had an opportunity for young investigators to present their posters, to get cutting-edge research out there. And we wanted to have open scientific dialogue and debate, not a lot of pontification, not a lot of dogma. We don't know a lot in this area. There's a lot of room to grow, and everybody who works hard and does things rigorously should have a seat at the table for discussing this. So what's coming up for 2016? Okay, this is the third year. The last 2 years we've had between 400 and 500 people attend, so that's done quite well. We wanted to add some things. We wanted to keep the parts that work, and then there were some things that people were asking for. Today we had a concussion clinical skills pavilion. We had one at AAN last year. We want to have a boot camp for concussion assessment at the next meeting. And that will include short presentations of different assessment tools, some of which are parts of the neurological exam, and some are which are screening tests that neurologists may not be familiar with but are being used widely in the community. We're going to have breakouts Last year, we added youth, sort of below that level of high school, to our agenda, and it was the most attended breakout session in Denver. So we're definitely keeping that in Chicago. We'll keep the regular didactics. We've shifted the speakers to keep it fresh. The research lectures are going to talk about things that are current and important in the news and important in the field. Impact sensors are a huge thing. Parents are buying impact sensors for their kids. We don't even know if they're validated. And they're basically out there as part of this concussion incorporated big business. What's the real data behind them? Come by and listen. There's advances in neurobiology, trying to link acute concussions with chronic problems. There's focus on pediatric research. Many papers using pediatrics, using children, are now being included, and many adult neurologists that I know also take care of kids. And then an important thing in the field is moving away from this idea of complete cognitive rest. Sitting in a dark hole somewhere is going to get you better from a concussion, and moving more towards what we've already learned from other conditions like headache and low back pain, is that you really need more active recovery. Okay? And putting kids or anybody in a dark hole and telling them to get better and not be anxious and depressed is wishful thinking. Okay? We're going to have a special breakout session on the role and responsibility of the media. Okay? And we're going to have several journalists talk about, what are the motivations and the pressures that they're under when talking about this, so that when we as spokespeople address neurological issues for the lay public, that we do so in a responsible fashion, not just to get the sound bite, but hopefully to transmit some meaningful information. And then another big important thing, our final keynote at the meeting is going to come full circle. Brian Hainline, the Chief Medical Officer for the NCAA, is going to talk about the CARE Consortium, the largest prospective study of sports concussion ever. Okay. Funded by the Department of Defense and the NCAA to $30 million. They've done over 17,000 baselines in a year and a half, over 600 prospectively studied concussions clinically, and close to 50 concussions that are also being followed prospectively with advanced MRI, blood biomarkers, and impact biomechanical sensors during the play prior to the incidence of the concussion. So all of these things will be sort of new and exciting stuff at the Sports Concussion Conference. It'll be in Chicago this year, July 8th through 10th. As neurological care providers, it's our duty to make sure that we stay up to date and that we help lead this field forward with our colleagues. And you're going to meet colleagues at this meeting from sports medicine, athletic trainers. Learn to talk their language, learn to work with them, build relationships in your community, and come and see us at the Sports Concussion Conference in Chicago. Thanks.